Hi everyone, my name is Magar and I'm one of the PGY1s in internal medicine, presenting my poster titled Critical Left Main Myocardial Infarction, presenting as delirium and hypothermia. So delirium, as we all know, is a very common medical consult. It's got innumerable causes. And here I'm sharing a patient I admitted overnight for delirium who ended up having a pretty severe STEMI. So this was an 84-year-old male referred to us for delirium. In terms of his past medical history, he was notable for coronary artery disease with a previous left main stent in 2019. He was on dual antiplatelets when I assessed him. He had advanced Parkinson's disease and a mild cardiomyopathy. In terms of his HPI, he was confused and poorly oriented, so I was unable to elicit a reliable history. Collateral from his wife essentially reported 2 days of increasing confusion and hallucinations, personality change, but there were no cardiac or respiratory or infectious symptoms. There were no new offending medications started. Vitally, he was stable when I assessed him initially, and his physical exam was largely unremarkable. His initial workup by the ED had a troponin of 62 down from 91 on arrival, a BNP of 136. His initial ECG showed no features of acute ischemia. CT brain was normal, and a chest x-ray showed some bilateral lung opacities and consolidation. The rest of his lab work was negative. I essentially admitted him for delirium, likely secondary to a pneumonia, and treated him with ceftriaxone overnight. Overnight, things kind of took a turn clinically. He became persistently hypothermic as low as 33 degrees Celsius, and this was despite a bear hugger, and it was felt to be secondary to sepsis. However, he further deteriorated and became hypotensive and hypoxemic at one point. I opted to trend his troponins, even though they were downtrending. I sent off a third repeat, which came back at 83, up from 62, but at that point, there were no changes on ECG to suggest an acute ischemic event. I continued to trend them, and the repeat a few hours later was 189. And at this point, there were some changes on the ECG, albeit being very subtle, and cardiology was consulted, who thought this was likely a supply-demand ischemia and recommended to continue to trend these investigations. A few hours later, troponin went up to 1600, and this is when we started seeing some obvious changes on the ECG. So there were some new ST elevations, AVR, V1, and then V2, and some reciprocal ST depressions in the inferior lateral leads. This patient at this point was obviously rushed to the cath lab, which essentially reported, I know the diagram here is small, but a 95% occlusion of the left main, particularly at the bifurcation between the left circumflex and the LAD, with some other notable changes requiring in total 7 drug-eluting stents and an admission to the CCU. So I think the important learning point from this patient was to not forget ACS as a potential cause of delirium. Importantly, it has been shown to be an independent risk factor for 6-month mortality. So, you need to have a very high clinical suspicion in the right patient, otherwise it's likely to be missed. Especially giving a very unreliable history and the patient is confused and can't tell you they have any chest pain. And when you think about it in retrospect, this patient's hypothermia, although it was felt to be secondary to sepsis, could have represented early cardiogenic shock, which was actually supported by an echo which was later done, which showed a reduced ejection fraction, which was new. So that's essentially it. Thanks so much for listening.